Hello, in this video, we're going to talk about postural distortions. And again, by postural distortions, just meaning like postural abnormalities or features of posture that we may detect during a postural assessment. So the first one is lumbar hyperlordosis. So the lordotic curve of the spine, that's referring to the anterior posterior direction of the curve of the spine in both the lumbar region and the cervical region. When that curve is in the extreme, then we might refer to that as lordosis or hyperlordosis. So this particular feature of posture would be an exaggerated curve in the lumbar spine. Usually the result of some combination of the things on this list here. So hypertonic hip flexor muscles or over-contracted, chronically contracted, hyperactive hip flexor muscles, large anterior abdomen like you see with pregnancy or obesity, but specifically obesity where there's large body fat in the abdomen, not necessarily if the fat is carried evenly everywhere, that's a little bit different, but large anterior abdomen, poor postural control, hypermobile lumbar joints, and other muscular weakness. So these things don't generally happen alone. More often, one will cause others on this list, or multiple could happen at the same time due to a different cause. But like hypermobile lumbar joints doesn't cause hyperlordosis by itself, but that plus poor postural control or other muscular weakness would add up to lumbar hyperlordosis. Kypholordotic posture is very similar to the one we just discussed, but in this case, we add to that kyphosis of the thoracic spine. So it includes a compensatory exaggeration of the kyphotic curve. So the kyphotic curve, again, referring to the anterior posterior angle of the spine, but this time in the thoracic region of the spine. So if we have hyperlordosis in the lumbar spine, to compensate for that, very often we end up with hyperkyphosis in the thoracic spine. So the two of those combined would be kypholordotic posture. So in this type of posture, the pelvis would tilt anteriorly due to weak abdominal muscles, multifidi, or the hamstrings. And all the spinal curves are exaggerated, which increases stress between spinal segments and fatigue supportive postural muscles. So the postural muscles end up overworking, and often as a response, they become hypertonic, and that can be pretty painful. It also tends to lead to forward head posture. So the hyperkyphosis in the thoracic spine will often lead to compensatory hyperlordosis in the cervical spine. So it goes all the way up and down the chain. So it can start actually in the cervical and work its way down, or it can start in the lumbar and work its way up. Okay, rounded back posture. Hyperkyphosis. So again, an extreme rounding essentially of the kyphotic curve in the thoracic spine that leads to hyperlordosis of the cervical spine. So again, that hyperkyphosis could be caused by lumbar hyperlordosis, but it also could happen with a totally neutral, healthy lumbar spine. We could have hyperkyphosis in the thoracic spine that then also leads to hyperlordosis in the cervical spine. The thoracic spine, in this case, would be in a chronically flexed position. The cervical spine is required to hyperextend. So if we recall the writing reflex, where it's our instinctive nature to have the horizon, to have our eyes and head level with the horizon. So to do that, we're going to hyperextend the cervical spine, which would put us into hyperlordosis to keep the head right with the horizon. Because otherwise, if we're hunching over, we're forward flexing in that thoracic region, we'd be looking at the floor. But instinctively, we don't do that because of the writing reflex. This is a result of chronically slumped posture, like when we're sitting at a desk working on a computer chronically, like many of us are. There could be other causes, but that is definitely in our world the primary cause. And then over time, if this is allowed to keep going chronically, this posture weakens and stretches the thoracic extensors, and then neck extensor muscles and pectoral muscles become hypertonic and shortened. Okay, so all these muscles in the front, so no, I want to read that again. The neck extensor muscles and the pectoral muscles, so in the front and the chest, sorry, those become hypertonic and shortened, so we hunch in here. And then meanwhile, the posterior neck muscles are also hypertonic and shortened, pulling our head up. And then these anterior neck muscles would become lengthened and hypotonic, which we'll see more of that in just a moment here when we get to forward head posture. Okay, a swayback posture is when the pelvis tilts posteriorly and shifts anteriorly relative to the feet. Okay, so we're talking about the pelvis tilts, it rotates backwards and then translates anteriorly. So the whole pelvis shifts in an anterior direction. So you can see in this picture how it looks like he's kind of leaning back and the pelvis is pushed forward. That's a swayback posture. So in this posture, the acetabulo-femoral joints are fully extended. The lumbar spine is hyperlordotic, but it's sort of like they're leaning backward into the lumbar spine. The thoracic spine is somewhat hyperkyphotic because the lumbar is leaning back and then their thoracic spine is leaning forward to get them to more of a neutral position. So they're hyperlordotic and hyperkyphotic, but with the pelvis shifted all the way forward. The head also translates anteriorly, so they're not necessarily arching it up, but each vertebra, one on top of the other, will translate and shift anteriorly so that the head's kind of drifting forward, but not necessarily arching up into hyperextension. Causes the upper back extensors and neck flexors to lengthen and become weaker. So as you're shifting forward, those muscles in the front of the neck are getting stretched, they're getting lengthened and weaker. So I always think back to the length tension relationship, where as they're becoming more and more lengthened chronically, the sarcomeres are pulling further and further apart so that when there's a signal to contract, they're less able to do that because there isn't enough overlap for them to grab on and pull. This causes spinal instability, so the joints of the spine become reliant on the inert structures instead of muscle activation for support. So there's the contractile structures that would refer to the muscle and tendon that contract together to produce force and actively move things or create active stability. The inert structures, we're talking about the structures that cannot produce force. So that would be like tendon, or sorry, not tendon, that would be like ligaments, joint capsule, cartilage, other passive inert structures that are not able to produce force. So the less capable the muscles are of giving a joint stability, the more we rely on the inert structures or the structures that are just passively restraining a joint. And that's not good because when we're relying heavily on the inert structures and not the contraction and force production of muscles, that puts those inert structures in danger of injury. So if we're heavily relying on the joint capsule and the ligaments, we're more likely to injure the joint capsule and the ligaments. Okay, flat back is when the pelvis tilts posteriorly but does not shift forward. So it's like sway back, with the posterior pelvic tilt, except the pelvis doesn't shift forward. So it doesn't put us into that hyperlordosis and hyperkyphosis. Instead, the spine straightens up. So it's the opposite. It's more like hypolordosis and hypokyphosis because the spine straightens up because it's stacked right on top of a posteriorly tilted pelvis. Causes flattening of the thoracolumbar spine. In this case, the hamstrings are shortened. They're pulling down on the ischial tuberosity, and that's part of the pelvic tilt. The hip flexor muscles become stretched and hypotonic, and the normal S-shaped curve of the spine in the sagittal plane is flattened. I've also seen this called military posture before. You know, and some people see this and think, oh, that's perfect posture. They're standing so upright. But if we're so upright and the spine is so straight, that we've lost the natural healthy curve of the spine, that is not a good thing. That is not proper posture. It's a flat back. It's an abnormal posture. And this one also often leads to forward head posture. But many people have forward head posture in many of these different spinal postures. All right, so now finally, what is forward head posture? It's when the head drifts anteriorly relative to the thorax. So remember, in good posture, we want to be lined up. We want like the mastoid processes to be roughly lined up with the AC joints. You know, we might be slightly anterior to that, and that's okay, but we shouldn't be significantly far forward compared to the AC joint. So cervical vertebrae translate anteriorly and lose the lordotic curve. So we're talking about vertebrae that are sliding forward as opposed to just being cranked up like this, as opposed to being hyperextended. We're talking about the drift in the forward direction. So we have a vertebra, one on top of another, just sliding that way. And then if they're all sliding that way, all 7, then we can have a pretty extreme forward head posture. It increases the stress on the posterior ligaments and joint capsules of the cervical spine. So the further anteriorly we drift, the more forces and the more stress the posterior ligaments and posterior joint capsules have to be able to withstand. Causes the cervical flexors to become hypotonic. So again, these muscles in the front of the neck get stretched out and aren't able to contract at a healthy level to control our neck movement. And meanwhile, the cervical extensors in the posterior side of the neck are hypertonic. So they're overactive and shortening as we drift forward. So this posture stretches the anterior fascia, so all that connective tissue in the front of the neck. It stretches the anterior fascia and extends all the way up into the temporomandibular joint. So all this fascia in the TMJ and then surrounding this whole front of the neck, that all gets kind of stretched out, and there's too much space there, and it puts a lot of tension because it's stretching chronically as we drift forward. So actually, someone who has temporomandibular pain, anybody who has pain in this joint, you want to look at their posture and see if they have forward head posture and pain in the jaw. It can be really helpful for that person to help solve that posture. So if you can help strengthen the right muscles and elongate the right muscles, that can actually take a lot of the pressure and weight off of the temporomandibular joint and help reduce that pain, if that's part of the condition that they're experiencing. Significantly increases the weight of the head on the posterior neck and upper shoulder muscles, which is partly why they become so hypertonic, is because in the posterior side, they're having to contract to such a greater degree to cope with the increased weight of the head as it's moving forward. Okay, the external auditory meatus, so the hole in the ear, normally aligns with the acromion process, but is anterior to the acromion process in forward head posture. So again, the ear should roughly align with the AC joint. We might be slightly in front of that, like maybe ½ an inch in front of the AC joint. But as we get further and further forward, we would start calling that forward head posture. The head might drift anteriorly for a variety of reasons, so poor postural control. It could be poor postural control just of the head and neck, or it could be as a result of all these other postures that we've been discussing. Poor vision can lead to forward head posture. Someone with poor vision who might be leaning in and squinting frequently, like to see the computer better or to see what they're reading better, to look at something closely. So poor vision, uncorrected, so they're not wearing glasses or contacts, could lead them to forward head posture. Use of bifocal lenses. So if somebody's frequently having to look up and down, up and down, and up and down in their glasses to be able to see close, see far, see close, see far, that sort of thing. In some cases, they'll start doing some unusual head movements to go with the unusual eye movements. And that could start to lead to forward head posture, again, just like poor vision that's uncorrected. Muscle fatigue, so it's sort of a lazy posture. And I'm not saying someone with this posture is lazy, but it's sort of a lazy muscle posture where if our muscles are very fatigued or we are fatigued in general, we'll start to kind of drift and kind of just sink into that posture. And then again, like I've mentioned, other postures like we've been talking about can also lead to forward shoulder, like forward shoulder posture can lead to forward head posture. All right, so forward shoulder posture. When the scapulae protract and the glenohumeral joints medially rotate, like we see in this picture on the left, leads to hypertonic scapular protractors. So the scapular protractors are overacting. They're chronically contracted. And then we have hypotonic scapular retractors. So the muscles that pull the scapulas back are not acting enough and they become overstretched. This commonly leads to hyperkyphosis of the thoracic spine and forward head posture, but they can happen distinctly separately. So I think people confuse that sort of rounded back posture or hyperkyphotic back posture with forward shoulder posture. They're not the same thing. This does not include hyperkyphosis. So this does not include that arching forward of the thoracic spine. This is merely a shoulder posture. So glenohumeral and scapular posture. Now, again, this could lead to or happen together with a hyperkyphotic posture, but this can happen separately. So in this case, the scapulas are forward and the humerus on both sides, the humeruses would be medially rotated like we see in the picture there, but the thoracic spine could be in a totally normal neutral position. So we see this with someone like who has their arms in front of them a lot. Maybe they sit with good posture at the computer, like their thoracic spine is in a good posture, but they still have their arms in front of them. So that could lead there. This also could be someone who is working out in an imbalanced way and creating muscle imbalances. We probably all know somebody who goes to the gym all the time and only wants to work like pecs and biceps. The show muscles, and ignores back and tricep and other muscles that help balance. And so somebody who does a lot of pec work and not enough back work, they'll end up in this posture where the scapulas are drifting forward and the glenohumerals are turning in. So it could be caused by poor postural control, hypertonic anterior chest muscles, like you do too much chest work, hypotonic posterior interscapular muscles like rhomboids and mid-trap, and then abnormal sagittal plane curvatures of the cervical and thoracic spine. So if we have other postures that could lead to this, like hyperkyphosis or flat back or just other abnormal sagittal plane curvature postures, could lead to forward shoulder posture. Chronic forward shoulder posture can lead to other things like acromioclavicular degeneration. So being in this posture chronically could lead to AC problems, bicipital or rotator cuff tendinopathy or impingement, and we'll get into those in more detail in a future lecture. Muscular weakness, myofascial pain and trigger points. So in layman's terms, that's what people usually call knots. So this will cause like knots in the muscle and the fascia, but there technically are no such thing as knots. It really means myofascial pain and trigger points. But trigger point, that's like what you feel when you palpate and it feels like there's a hard lump there and you would call it a knot. That's a trigger point. It will also lead to posterior capsular tightness because there's so much tension on the posterior capsule because it's drawing forward. So it's like the posterior capsule is being chronically stretched and there's a lot of tension on that capsule. Abnormal scapulohumeral rhythm. So that's the rhythm of the movement of the scapula with the humerus. They need to work together and have a normal rhythm and movement. Otherwise, we end up with abnormal movements, which will lead to other muscular imbalances and pain. It also could lead to thoracic outlet syndrome, which we'll talk about in a future lecture. But in short, it's where we have impingement of the neurovascular bundles, the nerves or blood vessels that are coming out through the neck and across the shoulder down to the upper extremity. So in thoracic outlet syndrome, we'd have impingement of those structures, which would lead to nerve pain or other sensory motor dysfunctions or circulation issues. Okay, scoliosis, that is a spinal deformity that may include torsion and lateral curvature of the spine and trunk. So generally speaking, there's usually some lateral curvature. So if we're looking at a posterior view, you would see lateral curvature. You know, it should just be completely straight up and down. And it also could include some torsion, so some kind of twisting of the spine. And that would be in the transverse plane, that kind of twisting. So there's different kinds of scoliosis. First is structural or congenital scoliosis. And so that would be where we have an actual bony anomaly, where the bones are shaped differently or positioned in a different place, where it's the structure of the bone that is actually the problem. So there could be like a lopsided rib cage that's present in upright and forward flexed posture. So essentially, if the person is upright and you can see the scoliosis, and if they flex forward at the waist, if they hinge forward at the hip, and you still can see it, then that would be structural scoliosis, compared to functional or acquired scoliosis that's caused by muscle imbalance, essentially. So muscle imbalance, poor postural habits, muscle guarding, asymmetrical use of the body, limb length discrepancy. So the difference is with the structural scoliosis, it's caused by an abnormality or anomaly in the actual bone and the structure of the spine. And so it doesn't change when you bend forward because there's nothing to do with your movement or your muscle contraction. Functional scoliosis is present because there's something going on with the muscles. And so functional scoliosis, you can correct by doing muscle work and strengthening the hypotonic muscles and lengthening the hypertonic muscles to correct and rebalance the lateral curvature of the spine. So you can tell if it's functional or structural, because if someone has functional scoliosis, you would see it in an upright position, but when they hinged forward at the hip, it would go away. So their muscles would activate, and as they hinged forward, the spine would line up correctly, and you would be able to see that the scoliosis goes away. So it'd be functional. So that'd be something you can work on with training and corrective exercise, and massage therapy, foam rolling, many different modalities could work together to correct it. Okay, scapular winging, we've talked a little bit about in past lectures. That's where we have the medial border of the scapula that's kind of coming away from the rib cage. So the scapula projects posteriorly due to hypotonicity, so not enough contraction of serratus anterior. So remember, serratus anterior is holding that medial border down against the rib cage. And it also could be hypotonicity of the middle or lower traps, or some combination usually. Serratus is usually the biggest culprit, but it could be some combination of the two. So it could be caused by muscle weakness of those muscles, or there could be some dysfunction of the long thoracic nerve, which is what supplies serratus anterior. So if there's some kind of injury or damage to the long thoracic nerve, that would interfere with its motor control of serratus anterior, so it wouldn't be able to produce enough force to maintain its proper posture. It's more apparent with overhead movement. So if you assess somebody in a neutral position and you're not totally sure if you'd call that scapular winging or not, have them abduct the glenohumeral joint and observe from the posterior and see what it does. Because the higher up they go, if it's scapular winging, the higher up they go, the more it will protrude. If it's not scapular winging, the higher they go, the more the scapula will be kind of pressed onto the body. So that'll help you distinguish if you think that's what you're seeing is a problem or not, because serratus will activate to a greater extent as the arm is going up. Okay, a raised shoulder is incredibly common. You'll see this a lot. It's a shoulder held in elevation while at rest. So when the person's totally at rest and you tell them to just stand neutrally and one of their shoulders is up, And to the person, they think they're in a totally neutral position. They think the shoulders are equal. Because when we have a raised shoulder, we don't feel it, we don't detect it. And that's because when we're there chronically, the brain kind of remaps where we are in space and remaps that elevated shoulder to be normal. The brain thinks that's its normal neutral posture. So if you say to the person, like, bring your shoulder down to neutral, they won't really know what you mean necessarily because it feels neutral to them. So unless they have visual feedback, like in the mirror, or if you palpated and pushed it down or something, they need some kind of feedback to be able to tell that that shoulder's high and they can bring it back down. So can be caused by habitually carrying a purse or backpack on one shoulder. That is usually the cause. That's the thing I see the most often. When somebody has that chronically raised shoulder, it's usually because they're holding a purse on that shoulder, always that side. They're not switching sides. They always have it on the right, or like one strap on a backpack. But so with that person, just tell them to lighten up the bag for one, if they can, and then switch sides back and forth. So that they're not always just elevating the one shoulder, because then the brain learns this is neutral. This is where we should be. We don't want that. The brain proprioceptively reprograms to accept the updated posture as normal. Right? Okay, hyperpronation and hypersupination. So hyperpronation would be, of course, excessive pronation caused by the medial longitudinal arch of the foot collapsing. So that when we're talking about the arch of the foot, there's actually 3 arches of the foot, but what most people mean by the arch of the foot is the medial longitudinal arch going the length of the medial side of the foot. So when it collapses, that puts us into hyperpronation. The collapse alters the angle of the talocrural joint, so our joint that does our dorsiflexion and plantar flexion, and that leads to excessive pronation. Causes imbalances throughout the kinetic chain that may be dynamically or statically observed. Like we talked about the other day with, or in a previous lecture, with regional interdependence, where when that foot drops into hyperpronation, we then see the medial rotation of the tibia, and we see all those changes that happen all the way up the chain. Hypersupination is excessive supination. That decreases the shock absorbing capacity. So when we're rolling out into hypersupination, we're putting a lot more force into the lateral bones of the foot, and we decrease the shock absorbing capacity, which is the function really of the medial longitudinal arch. So if we're not putting our weight through the center of our feet, we're losing that shock absorbing capacity from that arch and just putting all that force right into the lateral bones of the foot. So it predisposes the foot to stress-related conditions because we're putting all those forces into the lateral foot, and over time, chronically, that could lead to like little fractures and sprains and ligament tears and things like that in the lateral foot. Hyperpronation and hypersupination may occur during static posture, dynamic gait, or both. So those are features that we might observe just by looking and assessing posture, or it might be that in posture it's completely fine, but it comes through in gait. So as they're moving and activating muscles, we might observe hyperpronation, hypersupination, or we might see it in both posture and gait. Chances are if you observe it in posture, you will probably also observe it in gait, but is entirely possible for it to not be present in posture and yes, present in gait. Okay, Genu valgum and Genu varum. So valgum would be knock-kneed. So valgus and varus, those are 2 terms that are going to come up probably a lot in this class. Valgus is referring to an angle of a joint. So valgus would be like when the knees go like this, like in the picture on the left, where they're forming an angle. Like if you think of the angle with being like an alligator mouth, okay, the angle, the alligator mouth is facing outward. Okay, that'd be valgus. Varum, the angle, the alligator mouth is facing inward. Okay, like in the picture on the right. So we can discuss valgus and varus positions of joints, or forces being like forces that push that joint into that position. So like a valgus force on the knee would be one coming from the lateral side that pushes you into that angled position where the knees are together. Okay, so those terms will come up a lot. So genu valgum, that's knock-kneed, where the knees are in a valgus position. So medial displacement of the tibiofemoral joint that causes that kind of outward angle. Commonly caused by hyperpronation. So as the arches drop and we sink into hyperpronation, or muscle weakness at the acetabular-femoral joint, usually bilateral. So unless there's some kind of like hip or foot injury or something that would cause it to happen on one side, most people, when this occurs, it's both feet sinking in and both knees coming together at the same time. The distal tibias shift laterally. So down at the ankle, they're going lateral, which causes medial angulation, resulting in the knees being visibly closer together than the ankles. Okay, genu varum, that's the opposite. That's what we call bow-legged. And so then that would be a varus position of the knees, or a varus angle. It's when the distal tibias shift medially, causing lateral angulation. Hypersupination or structural anomalies at the hip may cause the knees to be visibly further apart than the ankles. So genu varum more often is some kind of structural thing happening in the hips, or it could be hypersupination for whatever variety of reasons. Okay, calcaneal varus and calcaneal valgus. Again, there's that varus and valgus. Again, just referring to the angulation and which direction they're going. So here we're seeing the valgus, where we got the alligator mouth pointed out, and the varus, alligator mouth pointed in. Okay, so calcaneal varus, like we see in the right picture, when the distal calcaneus shifts medially at the subtalar joint, this can lead to hypersupination during gait and predispose the individual to lateral ankle sprains. So this person, because the calcaneus is shifted to the medial side, they're going to be more likely to roll the ankle, which would cause a lateral ankle sprain. Calcaneal valgus is the opposite, when the distal calcaneus shifts laterally at the subtalar. This is a primary component of hyperpronation. So this is distinctly different from hyperpronation, but is one aspect of hyperpronation. So we can have calcaneal valgus without being fully in hyperpronation. So this is more common than calcaneal varus, just like hyperpronation is also more common than hypersupination. It can be caused by bad shoes, excessive body weight, and when the muscles aren't strong enough to cope with the excessive body weight or the forces, like if that person runs or something. And conditions of ligament laxity. So like somebody who's hypermobile and has an excessive amount of laxity in ligaments throughout the body would be more prone to calcaneal valgus. Okay, that is all I have for you in this lecture, and I'll see you for the next one. Bye.